So today I'm going to talk about articular disorders. This is going to be more orthopedic than, say, neurophysiological. But I think it's useful in treating TMD patients to have a classification system. I like this one because it's simple, and the structural or organic problems are problems that we typically fix with surgery, while the functional disorders generally don't need surgery. And we're going to start off by talking a little bit about growth problems. And it's important to understand the basics of TMJ growth, because the adaptive mechanisms that allow a TMJ to be healthy are based on the way the TMJ grows. And so if we understand growth, we can understand adaptive mechanisms. So the TMJ, it develops from a cartilaginous offshoot from the first arch. It grows a couple of different ways. It grows upwards and backwards, kind of like a long bone with endochondral growth. But then the rest of the mandible grows through membranous growth, a combination of resorptive processes, changing the outer shape of the mandible, and depository processes, adding both thickness and length and height. The mandible starts very flat in the fetus and at birth, and with development of the alveolar process and teeth, it becomes taller, and the ramus becomes longer. And so David Hatcher's done some interesting work looking at the impact on the facial skeleton with, in this case, a left condylar hypoplasia, and he's used cone beam CT to look at things like the resultant Richard-Navian, the canting of the maxillary and mandibular occlusal plane, the obvious asymmetry of the chin, things like dental crowding and dental impaction. And he's also used cone beam CT and capacity for volumetric measuring to look at the impact on things like airway. So growth has broad-reaching effects on the maxillofacial skeleton, on its orthopedic and dental development. Another example, this patient presented with the same kind of deformity. The difference is that she told me that she was getting worse, and that it had happened quickly, and she was having right-sided TMJ pain. And she showed me a Panorex from 4 years ago, and then my current Panorex. You can see how the right condyle has overgrown, and how there's been some bowing in the inferior border. And her bone scan was positive. Look how it lights up on the right side. She had canting in the occlusal plane. This is another little trick to look for. If you see them developing an open bite on the affected site, you know that the velocity of growth is greater than it's a fast process. It's fast enough that the maxillary dentition can't compensate with the changes that are occurring. So you know it's an aggressive process. So again, treatment planning like we would with orthognathic surgery to level the bones, to recontour the mandible, move the nerve, but in this case also to take the growing condyle out. So surgery involved the right condylectomy with the Laforte one, inferior border osteotomies, and I replaced her right condyle with a rib graft. And a post-operative change radiographically. She had a big condyle, and histologically it was just a condyle. It was just a big one, which is good to know because there are other things that can grow in the TMJ she'll see later. And that's her final result. I've seen her 7 or 8 years for follow-up now. She's a triathlete. She always comes into my office with a bicycle, and she carries the bike into the treatment room. She's great. Front of the ear. And so the suture can be tied. You can verify that you have moved the disc by looking at it with the arthroscope. And once you pull the disc back and tie it, the knot is just buried under the skin. And then right then and there you can function the patient's jaw and check whether you've changed the coordination between the disc and the condylar head. I'm going to say that all displaced discs do not need to be repositioned. You know, most of them don't, especially the ones that are already starting to adapt by changing their shape. But I will suture certain discs that are associated with painful locking or sticking, and if they still have a biconcave shape.